You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. Today we're looking at pre-hospital ultrasound. Over the last decade, pre-hospital ultrasound has been evolving from an emerging technology to a powerful clinical tool with real potential to transform decision-making in the field. So, from identifying life-threatening pathology in trauma, to supporting complex critical care interventions, to guiding time-sensitive treatment decisions, point-of-care ultrasound, or POCUS, is increasingly becoming part of modern pre-hospital care clinicians' toolkits. So in this special compilation episode, we're going to bring together 3 different conversations exploring the practice, standards and challenges of pre-hospital ultrasound. So we begin by speaking with Mike Palmer on examining the evolving role of ultrasound in shaping clinical decisions and its impact on patient care. We also look at how ultrasound works in practice. Then we delve into the broader applications of POCUS in critical care with Dan Nevin, discussing how ultrasound can augment assessment, improve diagnostic accuracy and support procedures in some of the most challenging environments. So finally, we speak again to Mike Palmer and turn our attention to trauma, exploring the evidence, governance considerations and practical realities of implementing an ultrasound practice safely and effectively within a high-performing critical care team. So whether you're completely new to POCUS or already incorporate ultrasound into your practice, these episodes hopefully provide valuable insights as to where the field currently is and where it may be heading in the future. Please feel free to rate, review and subscribe to the podcast, and we'll catch you again next Monday for our next episode on communication under pressure, pre-hospital lessons with Dr. Stephen Hearns, and we look forward to seeing you then. I do hope you enjoy.
Yeah, I think definitely understanding this aspect kind of makes you think about the practical points of view about scanning patients as well. But no, ultrasound, are waves or sound waves really that are frequencies way above what the human hearing can hear. But in medical imaging, we technically use kind of frequencies of 2 to kind of like 15 kind of megahertz. But 1 hertz equals kind of 1 second, and these probes kind of emit then 2 to 15 million waves per second. But that's constantly when you've got the ultrasound device itself, the majority of its time it's kind of waiting in kind of waiting or like a receiver mode. So these ultrasound waves kind of go out and they kind of reflect on bones, organs, fluid, or whatever you're scanning, and it takes that time to come back. When that image is coming back to the ultrasound probe itself, it kind of generates this kind of like 2D images, as we already know. But these ultrasound devices, or the probes itself, have got these kind of lots of kind of piezoelectric crystals. These crystals kind of vibrate. In other words, they're converted from electric magnetic energy to mechanical energy waves. And this kind of, these kind of how it kind of generates from this electrical to this, as I said, this 2D image. Frequency, does it matter? Well, definitely it depends on what your goal is with your ultrasound device, whether you've got it, we're talking today primarily about trauma, but do we want to use it for arterial access or intravenous access? So for that particular, we want a certain probe with a higher frequency. The higher frequency gives you that kind of like the finite detail of putting that kind of the needle bevel into a vessel. If you had a lower frequency probe, that would go deeper into the body to scan like an organ or a hollow kind of retroperitoneum in the abdomen, but it wouldn't be so good for getting IV access. So it depends. So yeah, frequency is really important. Have the resolution to be good, and the probe selection as well. So yeah, so to explain is you've got 3 typical type of probes. You've got your linear probe, which you've got that's for primarily for chest scanning. So looking at the for hemothorax or pneumothorax, that's we used for IV and access. You've got the phase array probe, which is a bit smaller rectangle, which normally that's for looking at cardiac echoing. And then you've got the curvilinear, which is kind of a longer rectangle, which is slightly kind of bent in shape as well. And that's when you can look between kind of rib spaces as well. So yeah, probe selection is really quite important. But you can get some devices on the market where one probe does it all, which you can do that. I agree. But for the best image quality, it is more useful to, especially when you're a beginner as well, to kind of select the right probe for what your goal is for using the device for.
Yeah, indeed, indeed. Could I get you to speak to just the reliability? We're starting to see the adage and evolution of people scanning and going straight to the operating theatre. That maybe isn't necessarily happening within the UK right now, and it's like you said before, more adjunctive rather than a definitive tool. But could I get you to speak to reliability really for detecting things such as hemothorax or hemoperitoneum in the field, and indeed I guess in a way to your own practice, how these findings are influencing management decisions.
It's definitely it's a really good question, because if you ask me, or what's the evidence behind ultrasound, it's really hard, because if you're with a patient who can get intravenous access, and then you've got the only option is oral or sublingual, or other types of pharmacological agents, you to come along and you get some IV access with an ultrasound, has that been assessed really? But no, when you look at in detail, it's a lot of ultrasound or pre-hospital care ultrasound now is a lot of retrospective data, and it gets a bit muddled then as well with the A&E data then as well. But even like one published, I'm sure you can put it in the show notes, that it concluded that that fast information pre-hospitally significantly hastens kind of like door to needle time or door to CT time. And I think like it's a really good point there, because I feel, I'm in a very privileged position where when I take my patients to a major trauma center, I speak to the CIC, the consultant in charge, or the TTL trauma team leader directly. And I like to think, if I spoke to them and I said, this patient's not a code red yet, so I'm not kind of transfusing them. However, they've got normal vitals, but they've got a positive fast. I'd like to think that that TTL's kind of ear would kind of prick up a little bit and think, oh, okay, here we go. There's something brewing here in the background. And it's that concept of having that information passed over and thinking it might change, maybe not our practice yet, but it might change your practice in an hour's time. And then, the same paper as well, published in the injury, said that, it doesn't reduce scene times. It can kind of change management on triage, transport decisions, and as I've been saying about hospital notification. But you just, we'll go into it. But when you think that you've got a scan and you're scanning somebody, and you don't want to be scanning them and thinking, oh, they're negative, okay, they're okay to go to like the local trauma unit. You just need to be really careful of the decision you're making, and be aware of your own confidence and competence with that scan. And when we look at it as well, that it was a lot of the time that in another paper is saying that ultrasound particularly has got really high specificity, but the sensitivity is not as good. So it's really good at picking up when people are really truly positive, but those other aspects when it might need like some serial scanning. So it might not be negative, that might not be positive now, but maybe in 45 minutes, an hour's time, it might be positive. So you just need to be quite careful there. And also we've kind of gone into another kind of subject with kind of governance, but when we look at ultrasound scans, and when you do scan patients, especially for example in the right upper quadrant, we need to be kind of like fanning, so really taking that whole quadrant into it, and videoing that as well, because it might look completely negative, but then you kind of fan through and there's the whole lot of blood. And it's hard. I think you do need to step back, assess, think before you make these decisions. And this is what makes a more of a rural service very different to an intercity service as well. And also that sometimes an ultrasound, I remember two clinical examples of that. The patient had so much surgical emphysema, the ultrasound was completely futile because it didn't show anything. But we kind of know at the diagnosis anyway. So I think you just need to think again. What I kind of say to people sometimes: what does the patient need now? What does the patient need in 30 minutes? And what does the patient need in 60 minutes? And if you do need, people argue the use of pre-hospital chest drains. there is definitely, we do all of them all the time. They're not as frequent, but we do them. But then also on the other contrary is that, can we get away with it? And it's a cleaner style, better to do it in hospital. And people will kind of sit on both sides of the fence with that. And I respect those both decisions really. But to answer the question, no, step back, reassess, and think really. But then on the contrary to that as well, sometimes we think, you know what, we're not too sure, we're going to go by land. I know we've got that opportunity to fly, but hey, it might save us sometimes 10, 15 minutes. But if we don't do that, we can go on the back of an ambulance and we can draw up the blood if needed. We can pull over and do the RSI if needed. So sometimes sometimes putting them in the back of the helicopter is not always the best decision either. Hope that answers the question.
Yeah, well, it does, because I think fundamentally it's slowing down to speed up. And as you were saying, just taking time to understand what the patient needs, and also giving yourself off ramps. And an off ramp would be, like you said, going by land rather than by air, because you have chance to pull over, you have chance to really change the treatment plan if the patient's pathology mandates. So it absolutely does make sense. And actually, there is, and this is a really key thing you've notioned towards this, is, there's a high frequency of stabbings in the UK in various areas, and there's also a trend upwards in Europe and in the US, and keeping on-scene times to a minimum is absolutely key, but still applying some critical thinking to that patient ahead of time, and not just by rote rushing the patient into an ambulance and rushing them to hospital, really thinking what they need, both now, 30 minutes and 60 minutes, and giving yourself these off ramps. I think, like you said, it's critical. And if there is any complexity, sharing that decision quickly, breaking the decision down, as you say, reach back is key if need be. Not at the detriment necessarily of the patient, but really starting to share that decision and giving yourself the off ramp opportunity. The last question is probably the most tricky, but something I was certainly within London doing on a frequent basis, both within trauma but also within medical cardiac arrest, which is using ultrasound as an adjunctive triangulation tool. That's a word salad, but I was using it with other diagnostics to not necessarily withdraw care, because care hopefully endures to the wider scene and wider family, but certainly to withdraw resuscitation. Using it with the ETCO2, using it with the ECG, but also certainly using it to really understand what the cardiac activity is doing in cardiac arrest. Is it, my question on the back of that, Mike, is it an adjunctive tool that you're using now on every cardiac arrest?
I think you alluded a little bit with your question as well, isn't it? That you don't roll somebody recognition of life extinct on just the end tidal due. It's that it's the adjunctive tool, as you say. Good question. I think 9 times out of 10 we're probably getting it out of the bag, yes. But is that kind of those stats probably a bit not quite right, because I'm probably in a service now that I get selected to go to certain cardiac arrests. I know we don't get dispatched to all of them, or the majority of them. It's a CCP, critical care practitioner, really kind of looked at that cardiac arrest and thought that we're there to add something. And also we're, a lot of the time now we're 20 minutes, 30 minutes behind, the ambulance crew as well, especially with the flight times or the journey times really. So we're there already really is to provide an enhanced care potentially. So I think to answer the question, yes, I do, but I think it's hard to say we should get out every time, because I don't go to every cardiac arrest. Does that help? Yeah. I don't know whether you could kind of add more to that, but I don't. Yeah, I do like to, and then also it's that thing as well that if you're scanning those patients as well, it's getting that. I don't want to say practice really, because it's not practice at all. But when you are scanning, going back to governance as well, you're scanning lots of people all the time. You've got that hands-on kind of practice really to kind of get those images really. And but we need to make sure that that time off the chest is minimal, and we definitely have protocols with that. And we probably go into the next podcast of how we kind of go along the lines of those protocols of minimal time off the chest. For example, you're not the person doing chest compressions. The ultrasound device has already got gel on it. It's all, you don't assess the chest or the ultrasound, the echo, whilst you're scanning. You save it and then you come away. So especially with our training, we have these 5 second periods of scanning and coming back and off. So it's a bigger decision really, and it can have some consequences. And definitely in the guidelines, it does say about keeping, chest compressions, defibrillation is still right up there, and it will be, I'm sure, for many, many years.
So, I mean, largely point of care ultrasound for us is just starting to try and drag some of our patient assessment into the 21st century. Our service, one of the consultants in our service recently published a paper on the utility and the sort of sensitivity and specificity of our clinical examination of patients in the pre-hospital environment, and just how limited we are with our basic tools, which are our eyes and our ears and our hands. Historically, we've considered ourselves, very, very skilled clinicians and very sensitive to picking up the injuries in trauma patients. But realistically, trauma is diagnostically done with radiology. So I always talk about the CT scanner as the donut of truth. And that's where you really get down to the bottom of what actually, the injury burden on the patient is. You can only surmise or, pick up grossly abnormal findings outside the hospital and the pre-hospital environment. So it became a sort of logical conclusion that once you have a way of looking inside the body, looking into a body cavity, that actually this must become an adjunctive element to our clinical examination. And we found, as I'm sure we're going to explore over this podcast, we found some really interesting things as we've started to add ultrasound to our clinical examination. And it just, when you pull someone out from under a truck or under a train and, they're hypertensive and tachycardic and they've got, a clinical picture of shock and a multi-system traumatic injury, it becomes quite important to try and pick out where the problems are, which body cavities the patients are bleeding into, or maybe one, maybe several, and adding that as an adjunct, has really become useful diagnostically for us. We've also found that historically some of our approaches to traumatic injuries have been very aggressive. And actually, by being able to be more diagnostically accurate, we're able to dial back on some of those procedural elements that before we would have a low threshold to deliver because we couldn't be certain that pathology was there or not. So we would proceed to treat it as if it was there. And now we can actually have a look and go, oh, actually, he doesn't actually have a pneumothorax on that side. We don't actually need to decompress that side of the chest. And actually, we can look for the problem elsewhere, fall back on whatever else we found as being the major issues here. So that's where we found it start to become really useful. What's also been interesting is the undifferentiated shock picture patients, where we think we have a handle on what's going on. So we think they're bleeding, and then we scan them and we discover they aren't. And then we realize that actually they've got a devastating traumatic brain injury, and this is a neurogenic picture. Or quite frequently, we go to patients who've been stabbed in the thorax or the abdomen. And it's, you might have a suspicion that there's a pericardial collection, but it's pretty interesting when you put that probe on and go, whoa, okay, whoa. We are definitely dealing with a patient with a pericardial collection who is peritamponade, and it really changes the way we address and approach the pace and the intensity with how we drive those scenes and those jobs. Similarly, it can be equally reassuring to arrive with someone who looks pretty awful and you're like, oh my God, what is going on here? This guy looks like, he could be peri-arrest, and I think he could have a tamponade. And we'd have a low threshold for delivering something like a thoracotomy for that patient. And you put the probe on and you're like, oh, wow, okay, that's pretty reassuring. His heart is thrashing away and it's pretty empty, but actually he doesn't have a collection there. And actually this guy is just hypervolemic, he's volume deplete. We need to restore that. And actually, we can calm down in terms of pulling out our thoracotomy kit and getting out our surgical gear. So, we're finding it speaking into a lot of elements of our patient care, diagnostically and therapeutically. And also, I think probably just in our crew resource management and how we determine the pace and the intensity with which we want to run the job. Different air ambulances and different pre-hospital services approach this problem very differently. And in the United Kingdom, a lot of emergency physicians, for example, as part of their training, are automatically accredited in level 1 ultrasounds and that sort of thing. We have taken a slightly different approach. So we have a very bespoke, but very specific, and actually a very directed and very didactic approach to how we use point-of-care ultrasound in our service. And I kind of think that you probably need to tailor it, like all of pre-hospital care, to your environment and to your workload. So we are a primary response trauma service dedicated to the City of London. We go exclusively to trauma. We don't go to medical emergencies. We go exclusively to primary response. It is within our remit to do retrieval work, but we virtually never, ever do it. We are primary response, pure trauma. Now, we looked at, when I was putting the ultrasound protocol together, we looked at various different protocols, the RUSH protocol and the, FUSIC and FICE and FAST and EFAST. And what I did was I took all of the stuff and I had a look at the evidence and I put all of it together. And then we did what we do fairly typically in doctor-delivered, high-end pre-hospital care services, where we take a complex in-hospital intervention, we then strip it out, we break it down to its absolute essential nuts and bolts and go, okay, which are the bits that are really essential here and which are the bits that are completely nice to have and that we would probably not bother with. And then we build it back into a simplified protocol. So we are basically probably a modified RUSH protocol if you wanted to be a strict purist about it. But we've taken some of the elements out and we've gone one step further in that we've simplified things even further, because we are often, pretty much exclusively on the scene with a complex, critically injured trauma patient several times a day in London. We are making high stakes decisions in a complex environment under time pressure. So our protocol needs to be very, very quick to deliver. We do not have the opportunity to spend 5 or 10 or 15 minutes scanning patients. So what we did is we took all the protocols, we amalgamated them together. I looked at the evidence of the best important elements of every bit of all sort of EFAST point-of-care ultrasound. And we've broken down it into a very simple didactic protocol that we call pump, pleura, and pouring blood. And this protocol is binary. So we are aiming to ask and answer binary questions and rule in or rule out specific diagnoses relevant to our patient profile. So when we say pump, the pump element of our scanning protocol is not even a full transthoracic echo series. It is a single subcostal window of the heart. Now, according to the literature and certainly to our clinical practice, that you can identify about 95 to 98% of the things that we need to see from a single subcostal window. Now, that's not to say we don't allow clinicians to use other windows of the heart, and where other clinicians are trained and accredited, we will review and comment and feedback on all elements that they scan. But the single piece of the pump protocol is a single subxiphoid window of the heart. And the questions we're aiming to ask and answer are, is the right ventricle dilated or does it look normal? Is the left ventricle pumping normally or is it pumping essentially like a wet paper bag? Does the left ventricle look full or empty? Is there a pericardial collection or not? Simple, straightforward, binary questions that you can determine without any measurements, without any advanced modes, without putting calipers and measuring numbers, just with your eyeball and a single subxiphoid window of the heart. The pleura components are 2 bilateral windows of the heart. Not the heart, the lungs. And we do those 2 windows on any part of the lung that is the most anterior, where you would see a collection of air in a patient who has a pneumothorax. And all we are looking for is the presence or absence of lung sliding and the presence or absence of B lines or comet tails. So we're looking to identify the presence or the absence of a pneumothorax. And then the pouring blood component is we are looking for massive hemothorax or massive hemiperitoneum. And we do one right-sided sort of costal margin window. So people would argue that you should do the full fast scan. We do not do the full fast scan. The most sensitive window of the fast scan is the right upper quadrant window where you can see Morrison's pouch, so long as you include the caudal tip of the liver. So we teach our clinicians to do a right upper quadrant window of the fast scan, looking into the abdomen, looking for Morrison's pouch and the caudal tip of the liver, which is where blood collects before it tracks into Morrison's pouch. Okay, and from that window, you can see blood between the hemidiaphragm and the liver. You can see blood in Morrison's pouch. You can see blood at the caudal liver tip. You can also move the probe upwards towards the chest, and you can see blood in the right hemithorax, just at the lower margin of the lung and the hemidiaphragm. And then we do a second window on the left side of the chest, and that would be essentially like the splenic window of the fast, but we're not actually looking into the abdomen. We are not concerning ourselves with the spleen. We are not concerning ourselves with the kidney or the splenorenal angle there. We are looking to find the hemidiaphragm, and we're looking for a collection in the left hemithorax. So on the right side, we're looking for a right-sided hemothorax, and we're looking for hemiperitoneum. And on the left side, we're looking for just a hemothorax. So with a pump, you get one window of the heart. With the pleura, you get one window of each side of the chest. And with the pouring blood, we are looking to see whether you're pouring blood into either of your two thoracic cavities or into your hemiperitoneum. Now, that's our protocol, and we are very specific, we are very didactic, but what we do allow the clinicians to have some free rein is where in the job phase they deploy the protocol. So sometimes the nature of the job necessitates that you scan the patient actually on the scene and on the job. Quite frequently, though, we find that our clinicians are scanning the patients in the back of the ambulance en route to hospital when they've already delivered some of their interventions, and they're now honing in diagnostically to see patient progression and progression of physiology and to identify further the areas of injury. And the other thing that we allow the clinicians to decide is that if they have a simple or single clinical question that can be answered by only one element of that protocol, they only need to scan that element. So typically what we see is patients who've been stabbed in the torso. They often get a pump pleura scan, when they've been stabbed in the thorax, and our clinicians are looking for a pneumothorax or some cardiac injury. Blunt patients often, or undifferentiated shock patients often get the full protocol, but we allow clinicians to determine what their clinical question is and whether a point-of-care ultrasound will help them in answering that question, and then they dive in and they can scan that element. Quite frequently, though, what we're seeing more from our data is that clinicians more and more are delivering the full protocol. The full protocol can be delivered in roughly about 60 seconds. It's very simple, it's very straightforward, and of course, as you've said already, it's very repeatable. What we instill in our clinicians is two things. One is that the evidence and the data in the hyperacute phase of trauma and point-of-care ultrasound, there is no data there. And so we often get to the patient's bedside 10, 12, 15 minutes after their injury. So a negative scan does not necessarily always reassure you that there isn't an injury there, so that the scanning is repeatable. The other thing that we train our clinicians is to only hand over positive findings in hospital, but not negative findings. So for example, if you've identified a cardiac injury or a pneumothorax or a hemiperitoneum, hand that over to the receiving hospital team. But if you haven't, we don't hand that over because we want and expect those in-hospital teams to repeat their scans down the line, particularly if the patient's physiology changes or any other element of their condition changes. And we don't want to wrong foot the in-hospital teams by them going, oh, well, the pre-hospital teams scanned this guy's belly and it was absolutely fine, half an hour ago. We can't really explain his tachycardia. Maybe he's just in pain now. And actually what we'd really like is that in-hospital team to be going, this guy's condition has changed from how he was half an hour ago. We should re-scan him and have a look. And we've had one or two cases, and this is interesting. We had a chap stabbed in the left flank, and here we were at his bedside, pre-hospital within 12 minutes or something after his injury. He seemed to have peritonism when he was examined, and he had a mechanism of injury that was highly suspicious for an injury in his left flank, something in the kidney or something in the spleen. But his initial pre-hospital ultrasound, he was negative for a hemiperitoneum. But 45 minutes later, in the emergency department, he had a positive VAST, and he needed to be taken to theatre for a laparotomy. So cases like this just reassure and reaffirm for us that negative findings need to be guarded with suspicion. But positive findings are, of course, very helpful diagnostically and in determining treatment trajectory. So I'm going to throw out some of the numbers because we review our data every 6 months. But, in a 6-month period towards the tail end of last year, we picked up 16 cardiac tamponades. And I'm really pleased to say that all but one of those patients survived. So because what happens is either they get their thoracotomy pre-hospital, or they get an expedited pathway straight into an emergency theatre when they hit a hospital instead of having a pit stop in the ED and a CT scan and various other things. One of those patients arrested got his thoracotomy and unfortunately had a hypoxic brain injury, didn't survive. But actually to see that volume of cardiac tamponades, 15, 16 tamponades every 6 months, and that's not including our patients who were found peri-arrest or in arrest who got a tamponade. So we're a service that sees a high volume of cardiac injury. We see a high volume of patients with cardiac injury with pericardial collection that we can identify pre-hospital, and we can expedite their pathway into the hospital to receive an emergency surgery in the timescale that they need it. So we have a very specific protocol, just to round off and come back to answering your question. We have a very didactic protocol, and we have stripped out the sort of complex and multimodal modality of point-of-care ultrasound, and we have turned it into a really tight, narrow, binary, black and white, yes, no, go, no go decision process where we then deploy the ultrasound in under a minute to answer very focused questions and then direct our next clinical actions.
Early decision making, that the trajectory is going down and quickly, it's altering and quickly. Right, let's open them up maybe pre-arrest, because that's where the survivorship lies. Could you maybe speak to that?
Absolutely. And I'd say there's 2 areas where I've seen our care, the way we deliver care, start to change since we've introduced ultrasound. And I'll come back to the cardiac one because it's a sort of more interesting one. But our baseline protocol for patients in undifferentiated shock, once they get intubated, they often just get bilateral open thoracostomies to decompress, either known or suspected pneumothoraces. We've actually dialed back on how many open thoracostomies we deliver, because once we put the tube in and we're ventilating them, we can actually scan them and go, yeah, there definitely is a pneumothorax on the right side, for example. Let's deliver a thoracostomy. Oh, hang on, there is actually nothing going on here on the left side. It looks pretty good. His chest feels okay. I've got some good lung sliding. I've got some good B lines. Actually, this guy does not need a thoracostomy on this side. So we are seeing a reduction in the number of open thoracostomies we're delivering since we've introduced ultrasound. And the second thing is exactly that, as you've alluded to. We're picking up an astonishing number of tamponades. In fact, just this week, we were reviewing the scans, and we've got a patient that just this week was attended to by one of our teams. The scan is beautiful. He has a beating heart thrashing away in a lake of blood inside of his pericardium. They were far from hospital. It completely influenced their decision whether to take him by road or whether to take him by air. And he was flown. He was only in the aircraft for about 3 minutes. He was flown straight to a major trauma center where he was taken straight into the cardiothoracic theater and had a sternotomy, and he had a right ventricle wound, which was repaired. And I think he might even be home already. So we're seeing a lot of that sort of thing. And we've had several cases where our clinicians have attended patients, and the patients are moribund. They're peri-arrest, but they're not in cardiac arrest yet. We've put the ultrasound on them. We've identified them in tamponade, and we have delivered their thoracotomy pre-hospital before they have suffered their cardiac arrest. We have relieved that tamponade, and those patients have all gone home. So what we are seeing is, as we we've always known trauma is a time-critical disease, but the data and the literature you're referring to from Zane is even more in stabbed heart patients is even more emphasized for us the time-critical nature of these patients, and we are seeing more and more that we are identifying patients pre-hospital who are peri-arrest but not in arrest, who have a clearly identifiable diagnostic intervention in point of care ultrasound, and we can see their tamponade and we deliver their thoracotomy, and we actually deliver a survivor to hospital who's already actually had his critical intervention, and he then goes to the operating theatre to be sort of more formally repaired. And those patients, all of the patients in our series have survived that have had an intervention just like that. There are two other things that we use our ultrasound for. One is for vascular access. We place a lot of arterial lines in our traumatic brain injury population, and in our patients where we think we may place a Reboa balloon, which is an endovascular balloon in the aorta. So we use our ultrasound for that, and we also use our ultrasound in cardiac arrest. So typically we'd image the heart, and we might image, to see where we think the patient's bled from or bleeding, or, in cardiac arrest. And so some of those jobs, so by virtue of the clinical picture and the clinical context of the job, or simply where you are in the building or wherever, that it mandates where you do your scan. But we don't, in the beginning, I used to say it's not clear enough where ultrasound fits into our clinical workflow to be able to be clear enough about it. Even nearly 2 years on, it's still very difficult to be too didactic about when, where, and how we use the ultrasound. I prefer, I suppose, to take a softer approach in that the ultrasound, certainly from the data and from the clinician experiences, sort of wins them over in terms of its value, and they tend to use it more and more as they get on with their secondments with us. But we don't say you must, you go to patients, truck's gone over someone's legs, their pelvis, belly, head, chest are all fine. We don't insist you've got to scan that guy. Like, we don't do that. And on the other hand, sometimes you've got a binary question. You do one scan, it answers your question, that's it. So we're not didactic about using it, and we're not didactic about where in the job cycle you must use it. We just train them. We strongly recommend it. And what tends to happen is it sells itself, because in the complex jobs, they use the ultrasound and they're like, oh my God, wow, I didn't see that there. I wouldn't have known that was there. And then, they are slowly won over if they aren't already sort of zealots. There are still some clinicians in our service who are not confident, who are not, I wouldn't say not competent, because we've trained them all, but and certainly inside of our governance onion, I'd be happy for them to do scans, but it's mostly a confidence thing. And then sometimes there is this illusion of it prolonging scene time, but we've worked pretty hard to make sure that our teams don't do that. And if it's just a nice to have scan, well, do it in the truck on the way to hospital. If it's I need to know the answer to this question right now, and the only thing that will tell me is if I can look inside this body cavity and get an answer, then I'm like, well, then there and there, you got to do your scan. Like, that is, that's clear to me. So we're like any other organization. We've got people who are still not zealots, and then we've got several enthusiasts who who are also highly skilled, who will do all sorts of scans outside and out with our protocol. So our protocol is our entry level, and we say that is the minimum scanning you should do. If people are skilled and competent beyond that, well, we will review those scans and give them feedback just like we would any other, and we encourage them to scan as much as they want to. But the bar is set intentionally low to answer binary questions so that all comers can pick up the probe and confidently approach the patient.
So Dan, looking at just a couple more questions really before we come into land. Where do you see ultrasound going within pre-hospital care?
It's a good question, and I kind of think that it depends on your service and what your service does. I'm aware of other air ambulance services slightly north of us. They use ultrasound to place, to place lines, to place central lines, to place arterial access. We've recently moved to doing a lot more radial arterial access for traumatic brain injury patients. So isolated head injury, isolated TBI, very tightly controlled blood pressure control. So arterial line, rapid sequence induction and intubation. For our service, I think at the minute we're probably we're probably about evenly balanced for what we should be doing and the kind of questions we kind of want to answer for the patient profile. There's several things we've thought of including, like when we put a Reboa in, should we be scanning the abdomen and looking where in the aorta the balloon is and that sort of thing. And I think there's scope to expand some of that. I think there's always a tipping point with interventions. And ultrasound is no different. I think, we could scan all sorts of things. You could scan the eyeball and, look for, you could measure the ocular nerve, and in patients with suspected, elevated intracranial pressure, we could scan, we could scan the aorta, we could scan, you could scan every kidney. There's a lot of things we could do, but I think there's a tipping point beyond which you start to move into the law of diminishing returns, where you're starting to get a lot less bang for your buck. And I think that's one of the sort of risks of something like ultrasound, because the more you become knowledgeable and skilled, well, there is no limit to what you can have a look at, with the right probe and access to a body part. You can pretty much scan anything. So I think there's a tipping point beyond which, it will stop adding value, and it will just add time and complexity unnecessarily. So I think for us at the moment, we're still pretty early in our ultrasound journey. We're coming up for 2 years, but I kind of feel that we've struck it, and it's been a learning journey. But I think for what we're doing and for the kind of work we do, we're probably doing the right stuff at the minute. There are things being talked about in our service, as you say, early femoral access, extracorporeal life support, all sorts of other things where ultrasound is undeniably going to play a role. I would like to see more ultrasound, as you say, in the hands of the advanced care paramedics and that sort of thing. Because if an advanced care team's coming and you've got a mechanism of injury like a truck over a patient, one of the things we're going to do is put an early femoral access in and be concerned about, is this a potential Reboa patient? So we've already seen, in our work, our advanced paramedic practitioners in London, it's great arriving on a job where one of them has been there before us, because the patient is prepped for the RSI, for example. So they've been, they're skin to scoop, they're immobilized, they've got 2 cannulas, they've got the full gamut of monitoring on. Like, we literally arrive and they're like, yeah, they're good for the RSI, And this would be no different. If you're carrying an ultrasound device as an APP and you've got a crushed pelvis, well, for us to arrive and you've already got the arterial line inserted and connected, well, what a win. And all of this is about cutting down time to critical intervention, and time to surgical hemorrhage control, and time to definitive care. So anything that would do that, I would say, can be put into the hands. And this is the thing that's been interesting in our journey, particularly with our paramedics, is that, we had a lot of people who were ultrasound naive, who were very intimidated in the beginning, and these are some of the images some of them produce now are some of our best scanners in the service, much better than some of the doctors, to be perfectly honest. So they've just taken hold of an intervention that is fairly easy to learn, and it's an intervention that the more you do, the better you get, and the more they scan, the more their confidence builds, and the better they get at imaging the patients, and there's no limit to this. So I don't currently have any grand designs for the future of ultrasound in terms of we're going to suddenly start, ultrasounding, the ear or something. But for our service, I think we're at the right place. We tend to put a lot of, let's say, landmark guided subclavian trauma lines. So we don't use it for line placement. We do use it for arterial access, but there are other services that serve, a high volume medical cardiac arrest population, and placement of an early central line using ultrasound to confirm the placement of that line is a key part of their work. And so this is the nice thing about ultrasound. It has a broad utility across the specialties, and it just kind of depends on your work volume and what you want to get out of it. But I think we're limited only by coming to that tipping point where we start to approach the law of diminishing returns, where we're going to start spending more time and energy doing more complex scanning for less return on that investment. And that's the only place where I think you've got to be a little bit wary. But otherwise, the world's your oyster, really, when it comes to ultrasound.
So it informs, I think, or confirms decisions. I think, yeah, that's probably a better way to say it, really, because I think you can be in a bit of a sticky wicket sometimes if you can't solely rely on a scan and then make decision of like, oh no, they're completely fine, they've got no free fluid in their belly, let's send them to a trauma center, and then all of a sudden we find out 2 hours later that they're having a secondary transfer. I think sometimes if you're maybe sitting on a fence whether using a major trauma tool, if that we use, the observations are all completely fine, and you're thinking, okay, if I didn't have an ultrasound machine in my bag, I'll probably send in quite rightly with what's been given to you to a trauma center. But then you've scanned somebody and they've got free fluid, for example, that's going to sway you, right, okay, no, let's go to the major trauma center. So that would definitely kind of swayed me, to go to a major trauma, more of a decision to kind of rule up more than a rule down. Because you need to be very aware that you can miss stuff, and as we said before, serial ultrasound scans and scanning is really important as well. You need to be thinking about what do you think is going on with your patient, what's the pathology that you think, and that's going back to when you're first in paramedic school, isn't it, that we need to be taught, okay, what's going on here, look at the mechanism of injury, look at the car crash, look at the engine block, out the vehicle, okay, what's going on, did they have a seatbelt on, have they been ejected, whatever. But then are you expected to find something? Okay, so let's look for that. And then I think that will kind of help guide the decision. So yeah, I think I take a very kind of proactive but dynamic kind of view and decision on that.
So, Mike, how do you approach balancing between avoiding false positives and ensuring you don't miss critical findings?
Good question. I feel that not to kind of repeat myself, but that making sure that you have that serial scanning, even if you're not really confident as well, having your colleague to scan as well. That could be another tool, or even say that, I'm not too sure, it's inconclusive. And I've definitely been in that situation as well, because I'm scratching my head, I'm thinking, whether this is right or not, are we going to make this decision? And this is the thing, whether you're trying to make a decision on what you're finding, what's the consequences of that outcome? And if the consequences is sending somebody to the wrong hospital, or whether you do or don't give somebody a blood transfusion, it's making sure that you want to make sure you make that right decision, but understanding what you're seeing really as well. And this is going back to making sure that how many people you do scan, you want to look at what normal pathology looks like. You perform an ultrasound scan, then you upload that to a drive, and then you write on a little kind of system where you basically say why you scanned and what you thought you saw. And then that will go to a reviewer and we'll look at the ultrasound scans, in the nice warm environment with a flat white, and think, okay, really kind of look, okay, do I agree with that? Or even sometimes they even say, well, they'll look at the scan before what they thought they saw as well. And then you get that honest feedback of what the governance, yes, I agree or don't agree. And then to another layer, Dan calls this the governance onion kind of layer. Really, there's another one that basically the reviewers reviews the reviewers, which is another kind of level, which is quite exceptional, really. And then with Wales, we've been in discussions with Dan about this as well, and how we can do this. And I think what starts off with is technology. I think that's, and what I'm kind of really kind of love with, I'm very fortunate with here in Wales, is that I can scan somebody and then convey to hospital. I'm doing my PCR on the computer, and I click search, and then an ultrasound scan is already on the computer. And that then, even before I've done all my printouts, the ultrasound scan is uploaded and it's on the system already. And that, I think that's what's fundamental then about the building blocks then of governance. Well, then we have, the top cover reviews the call and the mission, and then you can look then, and then people can go into it and review the scan and build that governance up. So if you don't have that governance there, or it's, before we've all kind of downloaded onto a pen drive or sent it over to like NHS email accounts and things, and it can be really clunky. And if the system's clunky, the governance can be clunky. It follows up as well. So yeah, to start off with that, I think you need to have that system, and I'm really fortunate to have that here in Wales. And then to go on with accreditation, one of the doctors that's kind of was leading it here in Wales is that knows how keen I am to doing my scanning and trying to build up a logbook, and he probably equated that it'll take me over a year to have proper supervision and to be accredited with other professional bodies. And it makes it tricky, even with training hours, with your other parts of your job that you need to keep up with as well. So we've kind of started this kind of like a 2-day course which follows the RChem guidance, but then it kind of brings the different aspects of what we already spoke about. We've got somebody on the floor with a Lucas on, how to manage that. We've got people on scoops. You've got people in bathrooms or whatever. It's like you need to kind of adapt to what you're training for. And if you don't do that, it's great to go into your level 1 course in a nice warm hospital environment on a nice bed at the right height, but it's not practical because it's not what we do. And that's what we've really realized really is that what can we adapt from these other agencies and accreditation to have a well-governed system as well. We went through that period of making sure that, yes, they're on standby modes. We've very fortunate that they had lots of machines, so we could swap them in and out at the start of every shift. A lot of ultrasound companies will say that they've got a good battery life, and they do. You can be left on standby modes and left for a 12-hour period. And we do that, and it's absolutely fine. It doesn't drain the battery whatsoever with the probe that we have. So that's definitely yes, 100%. And non-negotiable really is having that on standby mode, because even turn them on, all of a sudden what software it gives you an update, and it's frustrating, and then you open up the bag and then you're basically shoving it back in the bag. So it's definitely a key point there is having it there on standby mode. But yeah, and just being aware that you've got the gel ready in the same pouch, you've got all the sundries, you've got all the probe, whether you just have 2 probes or 1 probe or 3, you've got them all there ready to go really. I normally typically have it at the top of one of my particular bags where we keep it, so it's easier grabbed than lower down as well. So these practical aspects is definitely is there. And I think yeah, maybe being aware of the typical standard stuff really of lighting. We can't do it in broad daylight. It might have to wait till you're in the back of the ambulance because it's a nice sunny day and you've got no chance of seeing anything meaningful which you're going to make a decision on. So definitely being aware of that as well. And yeah, going on, what I've learned really is that aspect of handing over those, either positive or negative. We've got a bit of a thing really of that. If you hand over a negative scan, it might lead, the trauma team down a false sense of security really. And, we don't want to think, it's absolutely completely negative. And then, the HEMS team said it was negative, so it's going to be still negative now. And that can be worrying really, and we try not to do that, or don't do that really. We only hand over those positive scans to have that informative handover as well. Don't be afraid to get it out of the bag really. And if the time is right, we have got some time sometimes to do this. And if you're thinking, oh no, I'm not very good at it, or I'm not that confident, well, you definitely won't be confident if you don't get it out of the bag. So I definitely, I would say to encourage scanning. It's especially when the time is right, when you've got that period of time where you've on the way to hospital, you definitely can put your seatbelt on, put the probe on a right upper quadrant as well. You can definitely do that. And so why not really? I don't feel and when people say, it's not going to change your practice, let's keep it in your bag. Well, that's great, but maybe, I hate the word practice really, because we shouldn't be doing that. But what I do feel it does help the next patient when you've really made it feel comfortable scanning patients. And I know then it's because I've scanned so many people with normal pathology, I know that I'm really confident when the day comes when I really need to scan and it's all a bit heightened on scene, I've got that confidence there. So I would just say to encourage it, really, if I'm honest, and because you're not going to get any better if you don't do it.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.